So we're going to start with a data overview on this issue, and I'm going to go ahead and hand it off to Andrew West, who's our Housing Policy Fellow. And Andrew, just let me know when you need me to advance slides.
Great. Thank you, Alexis, for kicking it off and getting us started here. And thank you to everyone for joining and learning more about substance use disorders, the connections of homelessness. A little bit of a data overview, just a roadmap of where we're going to be headed here. We're going to begin just talking a little bit about what substance use disorder is. And obviously, we'll hear a lot more from our expert panelists a bit later. But we'll talk about the connection between substance use disorder and homelessness, the prevalence in the population of people who are experiencing homelessness, connections, and we'll talk about the unfortunate rise in overdose deaths, particularly tied to opioid use in the past few years, before moving into some solutions and sort of end on a positive note, talking about what we know works at the coalition. And we can go next slide. Beautiful. Thank you, Alexis. Here's one definition. I would note that there are different definitions of what substance use disorder is, but here's one from the Substance Abuse and Mental Health Services Administration, a well-regarded entity in this space. Substance use disorders occur when the recurrent use of alcohol and/or drugs causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. And that's sort of the point where we classify it as a disorder versus just substance use. And again, we'll hear more from our panelists on that. Again, it's important to note that when we talk about prevalence, numbers really do vary. There are a lot of different estimates. Different studies have found different numbers over different periods of time. But roughly, to give you an idea of what we're looking at, about 46.3 million people above the age of 12, which is roughly 16.5% of a population. So we're talking about a pretty significant number, met the applicable DSM-5 criteria, the standard for having a substance use disorder in the past year. And the DSM-5, for those who don't know, is the Diagnostic and Statistical Manual of Mental Disorders, published every year, that features the most current text updates based on scientific literature around a lot of different mental disorders, as they call it. And of that 46.3 million, 29.5 million were classified as having an alcohol use disorder, and 24 million had a drug use disorder. Obviously, there is some overlap here that we see in that number. I also think it's worth noting that it's not particularly always the most useful to separate the alcohol use and drug use disorder. I think it can be a little bit tough sometimes when we treat a lot of other drug use as if it's separate from alcohol, and that term I've heard, drug exceptionalism, I think Lisa Rayville called it last I heard. But we do know that, again, rates vary, but rates of substance use disorder are generally higher among people experiencing homelessness than the general population. And I will actually look at some of those numbers on the next slide here. Most research shows that about 1 in 3, a third of people experiencing homelessness have some sort of substance use disorder, and about 2/3 of people have a lifetime history, so that in the past, at some point in their life, they've had a drug or alcohol use disorder. An estimate from SAMHSA reveals that about 38% of people experiencing homelessness have a substance use disorder related to alcohol, while 26% had a substance use disorder with other drugs. So from that estimate, alcohol appears to be significantly more common. And like we saw on the previous slide, there is some intersection between the two. And in our Colorado context, the most recent number from the Colorado point in time count found that 2,564 out of 10,397 people reported chronic substance use. And that point in time count is conducted by Continuum of Care throughout the state of Colorado. And these are homeless service providers and other organizations that work together to really identify a live count of how many people on a given night are experiencing homelessness. We know that's not a perfect estimate, but it does give you a sense of what we're looking at, about 25% self-report chronic substance use. Thank you, Alexis. And when we talk about substance use disorder and homelessness, it can be both a cause and consequence, which I think is really important to note. At the coalition, we highlight health and homelessness. We highlight that there are a lot of interconnections between homelessness and other issues. That's obviously one of the main themes that we highlight in this education series. And I think it's important to note that substance use can be a cause that worsens financial hardships. Like we mentioned in the definition, once it becomes significant enough to impair one's abilities to work, perform responsibilities in school, in the home, leads to health conditions. It can also lead to housing, loss of a job, and that can be a catalyst to homelessness. On the other end, on the other side of the coin, we also find that once homeless, it makes it substance use disorder makes it difficult for people to exit homelessness. One reason is because there's a lot of stigma. A lot of people have difficulty accessing services, both because of the stigma and because of practical issues when people have a substance use disorder. We also know that when living on the streets, it can be very difficult. It can be traumatic day to day. And a lot of people use it as a strategy for coping with these hard conditions, as well as surviving. I think one thing we hear a lot from our providers is that it can be really difficult living on the streets. I think there's a narrative that people experiencing homelessness often commit crimes, but it's actually the other way around. People experiencing homelessness are way more likely to be the victim of crime than the perpetrator. And to survive, a lot of people can use substance use as a way to cope. We've heard about methamphetamine being used, particularly in the winter time to stay warm, and also at nighttime to sort of remain vigilant as a way to protect one's belongings, protect one's space, and sort of maintain awareness. But like I said, once you are homeless and you have begun and you've got a substance use disorder, it can be hard to regain housing, both because of stigma, access to services, and a number of other things. So the connection here is really, really circular. And we see that these things really reinforce each other, unfortunately. Next slide, overdose from opioids. One thing that we've seen in recent years with the fentanyl drug crisis, we have the most unpredictable drug supply that we've ever seen. And it's very dangerous. The number and rate of emergency department visits related to synthetic opioid overdoses that were non-fatal, both the number and rate almost tripled between 2020 and 2021, with the vast majority of these involving fentanyl in some way. And this presents unique challenges for people that are unhoused. Obviously, living without a stable place to call home makes so many things more difficult, but not having a safe private space where someone can use drugs makes it so that people often use in other unsafe spaces. That can be fast food restaurants, bathrooms, alleyways, parks, buses, other public spaces where it's much less safe to be using. We often talk about the coalition that the number one risk factor is using alone. The first responder in a lot of overdose cases is another person who's there. And if people are using by themselves, it can be hard to get a quick response and get the appropriate care needed to make sure someone stays alive. And we'll talk about some solutions to this. I know a lot of this is pretty daunting, and looking at some data on deaths from overdoses, the Colorado Coalition for the Homeless does a death review each year, and we found that the causes of death attributed to overdose has steadily increased every year since 2018, and now makes up about 50% of cases. Again, a lot of those are fentanyl related. According to stoptheclock.org, there is a fatal overdose about every 4 hours, 45 minutes, and 9 seconds in Colorado. All too frequent, which means that since 2000, we've lost about almost 18,000 people to overdoses. And unfortunately, that number is still climbing as we speak. Particularly adults aged 25 to 44 who are experiencing homelessness are significantly more likely to die from an overdose from opioids than their housed counterparts. So again, we see that not only we have a more dangerous, unpredictable drug supply, but there are also unique challenges for people who are experiencing homelessness, who often use alone, often don't have a safe place to do it, and often don't have a lot of resources to access treatment, harm reduction that they often need. All right, next slide. We can start to talk about some solutions. The coalition always talks about housing first as a primary solution. One thing that I've heard that I think is a good anecdote is that if someone's drowning, it doesn't do much use to insist they learn how to swim, but reaching out a hand and an anchor to get people stabilized is the immediate way to sort of help people out. And according to the National Low Income Housing Coalition, people in support of housing tend to reduce their use of substances over time when they're just provided with housing. That works at least as well, if not better, than other treatment efforts available within communities to help people reduce their substance use. And it's important to note that this is the case even if people are not required to seek out treatment. This is housing first, not housing only. So there are wraparound supportive services, but insisting that people treat their substance use issue is not necessary. We find that oftentimes when people are able to secure housing, things start to come together, right? People want to seek treatment, people brighten up, and you're able to focus on other things when you have that less immediate issue of trying to find a stable place to call home. Another solution that works is recovery housing. The coalition operates the Fort Lyon Supportive Residential Community facility, and that's in Los Animas, Colorado, and Bent County. This provides recovery-oriented transitional housing that really allows people to focus on recovery while stably housed. So it's that wraparound services approach, and it gives people really space to focus in. It's a voluntary program. It combines housing with peer support, educational, job training, employment services, all sorts of different things for up to 250 people at a time. A lot of those people are currently or formerly experiencing homelessness. And this is a great program that allows people to stay for up to 2 years and really assist people with getting back on their feet and reintegrating into society upon graduation. Something the coalition is very proud of. Another solution that works is an overdose prevention center. And these are sites where people who are using drugs are helped to do so in a safe manner, focusing on preventing overdose, keeping people alive, and also reducing the spread of HIV, hepatitis B and C. And we know that for a lot of people, treatment is not the only option, and we need to have a harm reduction approach that makes sure people stay alive. There are lots of overdose prevention centers currently in effect. There are hundreds in over 14 countries, and to date, no one has died from an overdose in one of these centers. But they're all associated with reduced overdose deaths, substance use related harms, and mortality across the board for people who do use drugs. They've also found to be associated with increased treatment engagement, reduced costs. So again, the number one prerequisite for someone seeking treatment is to make sure they're alive. And this often serves as a touch point to connect people to other treatment sources if they want. And they're not, as a lot of people think, a common misconception is that they're tied to drug trafficking, that people are going to start using substances or resume use of substances if they're in recovery if we have these centers. It does not incentivize people to begin using. Again, this is a harm reduction approach that really gives people a more safe place and produce overdose deaths. Let's see, next slide. What also works is naloxone. It's a life-saving medication that can actually reverse an overdose from opioids. I know we'll hear more about this from our panelists later. And that includes heroin, fentanyl, and other prescription opioid medication when given in time. It's important to note that while this is a very helpful tool, there are certain drugs that are non-opiates that cannot be reversed with naloxone. So this is not a one-size-fits-all solution, but is enormously helpful and certainly something we need to expand access to. And at the Harm Reduction Center, from between May 2012 and March 2023, almost 4,000 lives, 3,849 lives were saved with access to naloxone. And like I mentioned earlier, people who use drugs are often the first responders in the overdose crisis. Making sure people don't use alone means that someone else can be there to carry naloxone in the case that something goes wrong. Next slide here. And last one is medication-assisted treatment, or MAT, something the coalition provides with a weekday walk-in clinic where clients can meet with medical providers and peer specialists who are staff that have lived experience and support recovery, along with a support group for medication-assisted treatment. And what it does is it addresses the physical dependency of drug addiction by lessening the severity of withdrawal symptoms, helping a person return to normalcy in their brain function and behavior, and is, again, a really effective strategy for reducing this substance use disorder. And I think that's all for me in the data presentation, and I can pass it over to Aubrey now to Were the previous numbers for Colorado yes, those were for Colorado. And as a reminder, we'll send out a recap with the slides included, and we'll include this on YouTube if you want to use some of those helpful statistics. And I can pass it back to Aubrey here to introduce our lovely panelists and see if there's anything I missed.
All right, thank you so much, Andrew. My name is Aubrey Wild, and I'm the Advocacy Program Director at Colorado Coalition for the Homeless. And I have the pleasure tonight to introduce our fabulous panelists and also moderate the panel. Our first panelist tonight is Dr. Sarah Axelrath. She is a primary care and addiction medicine physician at CCH's Stout Street Health Center. She cares for patients in Stout Street's low barrier substance use disorder treatment clinic and people experiencing unsheltered homelessness on the streets of Denver. Lisa Barzak is a certified peer support specialist in the Department of Outreach and Engagement Services at CCH, where she runs medication-assisted treatment, or MAT, groups, which you just heard about, to support people in long-term recovery. Lisa brings to her work lived experience with homelessness, IV substance use, and mental health struggles, which allow her to provide an extra critical level of support to clients and also some great insight today. Lisa Rayville is the Executive Director of the Harm Reduction Action Center, a public health agency in Denver that works with people who inject drugs. Lisa is an amazing advocate, activist, and leader in the Denver community. And finally, Lisa Trujillo has served as the director of Fort Lyon at CCH since it opened almost 10 years ago. The Fort Lyon Supportive Residential Community provides recovery-oriented transitional housing to people experiencing homelessness on a beautiful campus in Bent County, Colorado. Thanks everyone for being here. So I'm going to start out with a question to all of you. We just saw a great data presentation by Andrew, but I want to ask, what do you think is missing from that regarding substance use disorders and homelessness that wasn't mentioned from a data perspective? And I'll go ahead and pass it to Sarah to kick it off, if that's all right.
Thanks, Aubrey. One thing that I just wanted to sort of contextualize about the data that Andrew presented is that when we think about substance use disorder, we think about the DSM-5 criteria that he mentioned, and a lot of that involves sort of compulsive, harmful use of substances despite negative consequences. But when we're talking about people experiencing homelessness, we really need to contextualize it in an understanding of the actual circumstances that they're experiencing and the challenges that they're facing. So for example, a lot of my patients use meth to stay awake at night, because if you can stay awake at night, you're much less likely to be robbed, assaulted, have your belongings stolen. And they may do that, they may continue using meth despite some of its negative consequences. It may make them anxious, agitated, it may affect their sleep, their mood. Those are all negative consequences that can occur from meth use, but they may be using meth for real adaptive reasons despite its negative consequences. So I just wanted to point out that the definition of a substance use disorder gets much more complicated when you are talking about people who have very limited resources, who are doing what they need to do to survive. And I have patients that use meth every day, but if I ask them about their methamphetamine use disorder, they would be very confused by that phrasing, because they may not identify as someone with a methamphetamine use disorder. They may just identify as someone who is doing what they need to do to stay alive. And if their goal is to stop using meth, and if my goal is to help them stop using meth, then more often than not, the best next step is to get them housing.
Would any other panelists like to add?
You got a lot of Lisas on here, Aubrey.
We sure do. We're going to take a page from the Bachelor Nation, and I'm going to use Lisa R, Lisa T, and Lisa B.
I feel like I'm in the 5th grade where there are 5 Lisas in there. Just something to point out is, I know it's very difficult to go zero to overdose prevention centers. So, we have syringe access programs. They're happening in 35 states and 92 countries. We have pipe access, especially in Denver, to make sure that we are focused on the drug market and drug trends that folks are using. Smoking is risk reduction over injecting. And I think as a larger part of what's missing from this, Andrew did an excellent job per the usual, but something else that we should really be having a conversation about, this is the most unpredictable drug supply we've ever had. we are in the worst overdose crisis we've ever been in. And so we will never treatment our way out of an unpredictable and toxic drug supply. So really having those conversations of kind of overdose prevention centers, safe supply, along with syringe access, pipe access is really important for our community, because I think it's a very tall ask to ask unhoused folks to be sober with all the crisis management that happens on the streets. So what we found a lot of, to Sarah's point, is, especially for our stimulant users, cocaine, crack, and meth, housing is substance use treatment, right? You don't have to use this chaotically. And especially when around, the holidays, there was the minus 40 degrees outside, almost all of my folks stayed outside and used meth as a survival method. And we do know that 5 people did die of exposure around that time as well.
So Lisa R., I wonder if you could expand a little bit on that unpredictable drug supply. What's driving that? And what is that unique impact on people experiencing homelessness?
Sure. So what's driving it is the war on drug users has been incredibly racist and classist since forever, but especially since June of 1971. And the response has been stigma, shame, incarceration, just say no and dare. And all that's done is bring us to the worst overdose crisis we've ever been in, with the most unpredictable drug supply. And it's called the iron law of prohibition. The harder the enforcement, the more potent the drug. So what's happening is heroin is leaving us due to climate change and lack of poppy cultivation. It's much easier to make a synthetic opioid in a lab than it is to deal with farmland and water access. So it's lather, rinse, repeat. We're already seeing new drugs off the East Coast, right? New class of synthetic opioids called nitazines, iso and pyro, and then also xylazine, which is a veterinary sedative, which actually makes sense. They're putting that in powdered fentanyl, which we now have here, to lengthen the euphoria. So we will never have a predictable drug supply. And as Andrew, my boo bear, said, there's 4 main reasons why people overdose. The first is the quality of the drug. The supply is unpredictable. Second main reason is any period of abstinence, coming out of jail, prison, treatment, living a life of recovery. Third main reason is mixing. So benzos and fentanyl, alcohol and oxys. And then the fourth main reason is simply using alone, by the very fact that no one's there to witness, recognize, or respond. So we will always have an unpredictable drug supply. We've never seen a community come back from fentanyl. So we need to be having real conversations, because we also need to be talking about, if this was alcohol and people were dying of unpredictable beers, this would be a completely different crisis with a completely different response. And it was from 1920 to 1933. And what happened is that people started dying and going blind, and they thought, well, maybe we should regulate it. So again, my boo bear, Andrew, was talking about this drug exceptionalism. I'm all done with that, right? We need to be having real conversations about what a safe supply looks like, and making sure that people aren't dying of an unpredictable drug, because people will use drugs forever and ever, and people have used drugs for never and ever. And our value base is that people shouldn't have to die of a preventable overdose. It is the leading cause of death of our unhoused neighbors in Denver, and it doesn't have to be so.
Thanks, Lisa. So one of the terms that has come up so far is harm reduction. So I'm wondering if somebody would be interested in jumping in and talking a little bit more about what harm reduction is at its core, and why is it a meaningful way to address substance use disorders? How about Lisa B?
I can jump in. Yeah, I mean, I feel like Lisa Rayville is the queen of harm reduction, so I was waiting for her to chime in, but she's already spoken a lot. I can tell you, as someone with lived experience, someone in long-term recovery from opioids, who is now on a methadone treatment program and has been for about 13 years, and doing very well on it. Harm reduction wasn't really around back then when I was still struggling. It basically means to me that you are going to really try to reduce harm. I mean, it's pretty obvious, like with the words, but it's, people are going to do what they're going to do. You're not going to stop it. Nothing has worked. The war on drugs has not worked. It's been proven. So what can we do to help people to try to keep them alive long enough to where they can start to be successful in their treatment? We're going to try to do things like safe injection supplies to reduce the spread of HIV and hepatitis C and other diseases. We're going to give people clean other injection supplies like cookers, cottons, waters, all of those things. We're just going to help people do what they're already doing as safely as possible. And then in the process, what that really does is humanizes these people that have been dehumanized for so long. I have never felt such hatred and cruelty as when I was living on the streets and when I was addicted. And I mean, people were just really, really mean. And this is what happens, you know, people pick on the homeless. And when you're able to go to syringe exchanges and other places like Stout Street and be treated with respect and dignity, be treated as a human, be smiled at, you know, asked how you're doing, those things really go a long way into revaluing our clients and making them feel like, okay, maybe I am worthy of getting better. Maybe I am worthy of trying these things. Maybe I can do it. And then when it comes to someone like me who's a peer support specialist, the whole point of my position is to provide that role model and say, hey, it's possible. I was where you were, I can do it. And when I was struggling, that was something that was lacking. Peer support wasn't really a thing back then. And so all I wanted to do was see someone who had been through what I had, that had gotten through, to show me that it's actually possible. Sorry, I know I kind of diverged from the topic, but that I feel very strongly about it. And you know, without harm reduction, it's back to the same. You need to get better before we're even gonna consider helping you. It just doesn't make any sense.
Thank you, Lisa B. Lisa T, can you speak to what harm reduction means to you as the director of Fort Lyon?
Sure. I think, you know, I understand harm reduction and the purpose of it. I think it's for people before they come to Fort Lyon until they're ready to try recovery. Of course, you know, Fort Lyon isn't 100% ever without its problems with relapse and so forth. They just cannot remain in our program at that time when they relapse, because we're zero tolerance. But the harm reduction to me is what supports them until they can get to us and at least attempt recovery.
Those are great points. So I'm curious if folks can jump in and talk about what the difference is between substance use and substance use disorders. At what point does it become a disorder? Dr. Axelrath, I know you spoke a little bit to how people might think of their own use patterns differently. So if anyone would like to expand on that, that'd be great.
I would love to start, because this is a question that like vexes me every day of my professional life. So I will start by saying, like, nobody really knows. Like, no one really knows when substance use becomes a substance use disorder. And I will say that substance use disorder, as I sort of alluded to earlier, is, you know, it's a made up category. It's not that it doesn't cause harm. It's not that substance use doesn't cause harm in people's lives. But the way that we've decided to define it, you know, in medicine, we need to like categorize and define things in order to study and understand them. And so the way that we've chosen to categorize and define substance use disorder is as arbitrary as, you know, where we decided to call the limit for hypertension. So we had to draw the line somewhere. And so I like to think of it as like comparing something to heart disease, like, you know, in the brain disease of addiction, which is sort of what the DSM-5 definition of substance use grew out of, we're saying that in addiction, the brain is the organ that's diseased. And relate that to heart disease. In heart disease, we're saying that the heart is the organ that's diseased. And when the heart is diseased, it doesn't function well. And it doesn't pump blood throughout the body. And it doesn't do the things that the heart is supposed to do to keep somebody alive and healthy. And so the brain disease model, which is really sort of, I think, tied in closely with the DSM-5 definition of substance use disorder, is saying that in addiction or substance use disorder, the brain is the organ that's diseased and the brain isn't functioning the way that it needs to keep somebody alive and healthy. And I think that that is an incomplete definition and a problematic definition. And I think we're seeing a lot of pushback against that brain disease model now, which I think is fair and deserved, because what you're really saying is that somebody who is in addiction or inactive or chaotic substance use has a diseased brain that's not capable of making rational decisions. But that's not what I see in my patients. I see my patients making rational decisions all the time. And sometimes the rational decision is to use drugs. And so I think we're not taking that into account when we talk about the DSM-5 criteria of substance use. Again, as I sort of alluded to earlier, sometimes continued drug use despite negative consequences is the better of two bad options. And it may be rational and it may make sense for that person. And especially when we're talking about people experiencing homelessness who might be very limited in their better choices. Sometimes substance use is the best choice available to someone. So the line between substance use and substance use disorder is very, very gray to me, very, very fuzzy. In some ways, I think it's really more up to the person themselves to define it. When your substance use tips over from a situation where it was helping more than hurting to hurting more than helping, I think then we're in the realm of substance use disorder. And then we can talk about treatment and goals to reduce substance use, reduce risky use, reduce consequences of use, work towards abstinence, whatever that person's goal is. But I think that as medical providers, we need to humble ourselves a little bit and recognize that it is largely up to the person themselves to define when their substance use has become problematic and in what ways, and then support them in working towards addressing those challenges and meeting their own goals.
Yeah, I can speak a little bit to this question. While that, I don't know, I guess disorder makes me feel like it's more of a medical term, but I can speak at least to what I personally would feel like would make someone like an addict, or what made me more of an addict instead of just a substance user. So to me, it's basically when it's causing problems in your life and when you're not able to stop, even though you want to. I mean, it's kind of pretty simple. There are lots of people that are able to drink every day and they're not considered alcoholics. It doesn't cause them problems. They're able to stop if they want to. It's not a big deal. There are people that are able to use, opiates and methamphetamine and other things recreationally. It doesn't mean, a lot of people think because, oh, those are serious drugs, you must have an addiction issue if you're using them. There are a lot of people, that use them and it doesn't cause issues in their lives. And it's not that deal that they're able to stop when they want to. So for me, accept, okay, I want to stop, I'm not able to, I need help with this. So that it's that acceptance of, needing outside help, really, I guess, is the best way I can put it. And then there are some people that are continue using others for a lot of the reasons, like that Sarah mentioned. Another thing I wanted to,
Lisa B, you're breaking up a little bit. Maybe try with your camera off. Right, if you need to fiddle around with your settings or log off and log back on, that's fine too. Thanks, Lisa B. So as Andrew mentioned, there are 46 million people across the country who are suffering from substance use disorders. However, that might be defined. Oh, Lisa B, you're back. We lost about a minute there. You were frozen.
yeah, I apologize. I don't know why it just kicked me off for some reason. Yeah, the next person can go. I kind of lost my train of thought.
Sarah, would you mind speaking to what you just put in the chat?
Yeah, I was just emphatically agreeing with what Lisa B just said. There are lots of people who use heroin and crack and cocaine and meth recreationally and potentially even regularly recreationally, just like there are people who drink 4 or 5 days out of the week and it doesn't cause any significant problems in their life. I don't get to know those people because those aren't the people who are coming to me for help with anything because they're functioning. They're working, they're paying their bills, their relationships with their friends and family are thriving. They don't need me. But there is nothing, I don't think there is anything intrinsic to the drugs that have been stigmatized as like, quote unquote, hard drugs like heroin, meth, crack, there is nothing about those substances in particular that makes a user of those substances more likely to develop a substance use disorder than a person who uses alcohol, nicotine, marijuana. You know, it is not a quality that's baked into the substance itself. It is more a factor of sort of somebody's own kind of brain chemistry, social environment, the way that they grew up, their circumstances now. There's many factors that may increase someone's risk of developing what we are now calling a substance use disorder. But strictly just the drug that they choose to use is not actually a significant factor.
I would have to say, though, one exception, in my opinion, would be opiates, because you become physically dependent on that drug and you become an addict essentially to, with that drug. And I mean, I'd say at least, I don't know, maybe 25 to 50% of the clients that come through like the MAP group began because they have chronic pain. And that pain doesn't go away when they get into recovery or when they get onto a MAT clinic. So they still struggle with that. And it becomes very difficult for them to kind of separate the two, like their pain and then the treatment for their pain. Someone who takes pain medication for a surgery or something and then is all of a sudden cut off from that medication, they are then kind of finding themselves addicted to this medicine, even though maybe they're not they weren't abusing the medication in the first place. They were taking it as needed, as prescribed, but then they find themselves without the medication and then they turn to street drugs. And then I don't know, it's tricky because I don't really know what then makes them an addict necessarily after that. Like if it's the behaviors that go along with having to buy drugs illegally as well as use them illegally, and you do illegal things to get the money and everything. I kind of feel like that all fuels that addiction, if that makes sense.
Yeah, I hear your point and I agree with you, Lisa, that, in medicine, we would consider someone who's taking an opiate painkiller as prescribed. They are not necessarily addicted to that painkiller, but they are physically dependent on it because that's just a property of all opioids. All opioids produce physical dependence, sort of in the same way that someone with type 1 diabetes is physically dependent on their insulin. They're not going to do well without it. They're going to experience really significant withdrawal symptoms without it, which might actually even be life-threatening. But what's interesting is then, when we cracked down on opioid prescribing, we took all these people who were opioid dependent and we now took away their supply and we forced them to the black market. We forced them to do illegal things and make riskier decisions and face worse and worse and worse negative consequences in order to just meet their physical dependence. And then we sort of created the diagnosis of the DSM-5 diagnosis of a substance use disorder around someone who continues to use drugs despite these negative consequences. But in some cases, I think there are just people out there who are using drugs to maintain in many cases, to maintain their physical dependence. But because they're reliant on an unpredictable and illegal drug supply, they are facing these negative consequences and they are continuing these behaviors regardless. And so I think the line between dependence and substance use disorder, again, I think is very gray. But I think part of that definition of substance use disorder is very much sort of constructed by us and what we've decided is appropriate behavior around these controlled substances.
Let's dig a little bit more into that stigma discussion. As Andrew mentioned, there are about 46 million people who are dealing with a substance use disorder. Most of them are housed. So people who are using drugs can maintain housing. So what do you think leads to this flawed assumption that substance use disorders lead to homelessness, or that everyone who is experiencing homelessness is facing a substance use disorder? Lisa, please.
Thank you. I'd say right off the top, people who don't know anything about people who use drugs think they know everything about people who use drugs. So I think, what we've tried and what the response has been to the war on drug users for years is stigma, shame, and incarceration. And all that's done is double down on the worst ideas of the drug war, which are incarceration and criminalization, meaning folks are at higher risk of acquiring HIV, hepatitis C, and dying of overdose. So we're really trying to do something different, and we really want to be supporting folks for a healthier and safer them today. We've never had a good conversation about drug use. So, you know, when Andrew brings forth evidence-based, data-backed interventions, sometimes people's tummies hurt, right? And evidence-based interventions and tummies hurting is not the same thing, you know? So evenings like this, I think, help really reduce the stigma of working with folks. And, you know, again, the drug exceptionalism piece, like we have no problems talking about happy hour, right? But then we have issues with talking about people who use meth, cocaine, opioids, and managed use is completely possible. We do it all the time with alcohol. And a lot of times people can do it if they have housing and money. Rock stars do it all the time. It's when you're unhoused, in and out of incarceration, not eating, because I think it's a very tall ask to ask unhoused folks to be sober with all the crisis management that happens on the streets. There's a lot of violence against people who are unhoused, specifically by housed folks. The top 3 things that happen nationally are beatings, assault, and being set on fire. So we, you know, a lot of people are like, well, I'm doing just fine in my home. I don't understand why people can't, because you're always publicly using too. And so when you can't get into a bathroom to inject, you use outside, in alleys, in parks, and in business bathrooms. So what we're trying to do with overdose prevention centers too is reduce that public drug use, but also restore dignity for folks too. A lot of people would rather be drinking inside than drinking outside.
Lisa R., would you mind talking a little bit more about what you do with your team at the Harm Reduction Action Center? How do you provide some of those direct supports for people who do use drugs?
Sure. So the Harm Reduction Action Center is Colorado's largest public health agency that works specifically with people who inject drugs and people who smoke drugs such as crack, meth, and fentanyl. So we do 4 things. First and foremost, direct service. So we have syringe and pipe distribution, access to Naloxone, people who use drugs are the true first responders in this overdose crisis, access to fentanyl testing strips and xylazine testing strips, so you can test your drugs to see if fentanyl or xylazine is present. Resources, referrals, things like that. Access to food, hydration, mail, HIV, Hep C testing. Then we do community engagement. So we have a volunteer leadership cultivation program, health education classes. We do a litter cleanup in the neighborhood. It's one thing to say you're going to be a good neighbor. You got to show people you're a good neighbor. We also do street outreach in high drug traffic areas and encampments. The third thing we do is advocacy and policy. We've passed 7 pieces of statewide legislation and made 3 Denver city policy changes in the last 14 years. We believe the streets should influence the policies at the state capitol and with Denver City Council, and we really need to be chipping away at our archaic and racist drug laws that Colorado has. And the 4th thing we do is technical assistance for bureaucratic institutions in which our folks intersect with daily, such as law enforcement, parole, probation, healthcare providers, neighborhood associations, talking about what we do and how the challenges and opportunities of working with people who use drugs. So if folks are interested in a tour, there's no good media representation of a syringe access program. People assume it's a dark and dingy home. There's actually a lot of life happening in there. But that's also why we're leading the fight to have an overdose prevention center. It would simply be a program arm of an already flourishing syringe and pipe distribution program.
So what are the gaps that you see that remain as far as what HRAC is able to do and what you can't do because of policy or funding barriers? You mentioned overdose prevention centers. What else?
Yeah, I mean, we're very clear that there's a lot of harm reduction 101, right? People have naloxone, fentanyl testing strips, syringe and pipe distribution. We need to talking about 2.0 stuff, and agreed, it is overdose prevention centers and it is safe supply. We need to be really having those conversations with folks, just like, you know, a safe supply of alcohol didn't solve alcoholism. It certainly solved the criminalization around that, right? We know that, you know, Colorado Department of Corrections overdoses are up like 300%, and the media is trying to tell us it's fentanyl in the paper. No, babe, that's misinformation. It's the guards. So there's a lot of misinformation out there. So it's really important that, you know, we go to evenings like this to make sure we chip away at that misinformation. I'm not asking anybody to leave here waving their harm reduction freak flag. If you want to, we'd love that. But part of my job is taking people from a place of misinformation to neutral, because misinformation kills people. and it's been killing people for a long time, much like abstinence only for a lot of people kills people. So what we want to be having is better conversations about medication assisted therapy, because also that's the gold standard when you're talking about opioid use, methadone, Suboxone, sometimes Vivitrol, right? But there's still a lot of stigma against that in the community. Have you ever tried to see a methadone clinic try to move into a community? Oh my goodness, all the NIMBYs come out. They don't want treatment in their community. And then we also need to be having real conversations about, talking to middle schoolers and high schoolers to have realistic conversations about drug use. DARE's back. I don't know how this happened. And cops doing drug education is like nuns doing sex education. It's not right. It doesn't work. You need to make sure that folks have really good information. So there is a curriculum from Drug Policy Alliance called Safety First. So if anybody on this call is roommates with a middle schooler or high schooler, you have got to talk to them tonight, especially about fentanyl, because it's not only for our folks that are unhoused, but one of the main reasons is legislators have legislated us out of a safe supply of pills. So it's not like people are like, oh no, thank you, good sir, I shan't be taking pills. They're going to the streets and getting the same unpredictable drug supply as everybody else.
And Lisa, I know you said that we don't have to fly our flags, but I got mine handy here. So I'll wave it real quick.
Right on cue, AW. Thank you.
Anytime.
Love to see it. Now, Lisa T, I'd love to turn to you. Can you tell us a little bit more about the unique program details at Fort Lyon, including the day-to-day of the program and how it integrates housing with treatment?
Sure. It's kind of like what everyone was saying. It is hard if someone wants to start a recovery journey. It's hard to do it on the street. You just can't really do it. So coming to Fort Lyon, especially coming out of the city, it can be a little scary. We're out here in the middle of rural Southeast Colorado. As a matter of fact, if you hear anything, we're in the middle of a huge lightning storm right now. So anyway, so Fort Lyon, we have 550 acres. It's a huge facility, and we really give people time and space to recover. We're not here to tell you what to do every day. You have to do this, you have to go to this group, you have to do this meeting. That's not what we're about. We give you tools, we have meetings, we have case management, but they have to decide what is their journey, because it's going to look different for every person. And if you try to make someone recover, it's not going to work. When we do our applications, that's one thing that we look for. Does this person want to recover, or are they coming here because if they don't, they're going to go to jail? That's probably not going to work, because again, it's not coming from the heart. And, people will get here, want to recover, and they relapse. We understand that relapse is part of the recovery journey. Let's try again. So we're really here just to give people safe spaces to recover, and they can work on school. We have people that go to our community college in our neighboring community, get their associate's degree. We have vocational training. We've got modules where they can work in our kitchen, they can do housekeeping. And in January, Colorado Coalition took over the second half of the contract that's at Fort Lyon, which is the maintenance of the entire facility. So that opened us up to be able to hire current residents, and they can work with the maintenance crew. They not only earn a wage, but they also might learn, different areas of maintenance, such as painting, landscaping, plumbing, that type of thing. So we have a wonderful creativity room where if people are interested in art, we just try to respond to what the community at the time wants, because once in a while there'll be a lot of gardeners and we'll have a huge garden because we have a lot of agriculture space. And then we won't have anyone for a while interested in it. So the garden will look a little weak for a while, but then it'll come back. So we really listen to what the population is interested in. And we have case management. So everybody is assigned a case manager. And then we also have peer specialists. And we're all just here to help the person on their journey. And the ultimate goal is permanent housing. So we have a transition team that works with residents as they're going through the program to get to that goal, to find permanent housing. Where do they want to live? A lot of people, come from the metro area and they decide they want to stay in our area. People that transition out, we have what's called Friends of Fort Lyon, and it's for former residents, and they meet once a week. We have staff that go, and former residents meet and get support and so forth. And maybe they relapse and need to come back again, so we're here for them. So I just think it's a real self-driven program, and we're just here's the tools, and we're here to support you. Like your cat.
My cat Bruce is also here to support. Lisa T, you spoke really beautifully to how everyone's journey looks a little bit different. So Lisa B, I'm curious, for those who do want to make a recovery and address their substance use disorder in some way, what are the things that a peer specialist can uniquely do to help somebody do that? It's possible that Lisa B might be frozen again. All right, we can come back to that. So Sarah, for those folks who want to seek treatment, what would you, including medication-assisted treatment, support groups, behavioral health assistance, how would that work? How would somebody begin that journey?
Well, thank you for that question. That is what I do, my bread and butter. So I would say there are a couple of keys. One key is that when someone has made the decision that they are ready to make a significant change in their substance use, whether that's abstinence or reduced use or changing their route of administration to something safer, or any positive change that's meaningful to them, the key is getting them in that moment that they're ready, because that is a really, really powerful moment. You have this window of opportunity when the stars have aligned. For whatever reason, they are feeling like this is the time and they're ready to make this really difficult and important change. And you need to be there and be accessible and be low threshold and low barrier, and they need to be able to access you. So that's a huge problem that we're dealing with right now across our city, across our country, is that there is some treatment out there, but that treatment is not accessible to most people. Most people don't have the insurance, or can't do private pay, or can't go to a methadone clinic every single day because they're trying to work. So we have some treatment out there, but we've made it really inaccessible. And that's not going to work when you have someone who has this 24-hour window of just feeling really motivated. You need to be able to really loop them in at that moment. And then you need to not punish them for trying. That's another thing that we get wrong in treatment, is we know that this is hard. This is really difficult. People are really vulnerable and they're trying. And sometimes they're not going to succeed, or they're going to fall down a little bit and stumble. And we have a lot of addiction treatment programs out there that are punishing people for their urine drug screens, for missing appointments. And it just doesn't work like that. You need to be able to support people through their journey. And if that makes you uncomfortable, maybe you're in the wrong work, but you need to be able to sort of sit with people and understand that not everyone's going to meet your expectations. And in fact, your expectations aren't actually what matters. What matters is the person's goal in front of you. And so it is both a problem that there's not enough treatment available, and the treatment that's available is just not meeting the needs of the people who want the treatment. We need different types of treatment. We need better types of treatment. We need more harm reduction focused outpatient programs. We need more sobriety focused inpatient programs. We need the whole spectrum. But the key is really being able to tailor your treatment to the person and their needs. And I think a lot of times that's where we're falling down right now.
Lisa B, as a peer specialist, what are the unique elements that you're able to add to this whole spectrum?
Well, I mean, like Sarah said, and something that I love about my work is that the whole point of being a peer support specialist is to meet the client where they're at. It's not to say, hey, this is what you need to do, and if you don't do it, I'm not going to be able to help you. Or, hey, I know what's going to work for you, so that's what you need to do. It's about really helping them come to that realization on their own and have their own small, realistic goals that they can set. Not everyone needs to just stop using everything all at once. You know, that doesn't need to be the goal for everybody. Some people are able to stop using one substance and still use another. You know, I am able to stop using opiates. I'm on a methadone program. I can still have a drink when I want to. It's not a problem for me. It never was. And I don't need to feel guilty about that and not being in complete recovery, like a lot of people would say, oh, you're not in recovery, you know, you're still using something. And a lot of people say that about MAT treatment as well. You know, you're still addicted to something, so it's not a real recovery. And that is just so dangerous and so toxic. And I have clients every day in group tell me that people in their lives are telling them, oh, you need to get off of that Suboxone. Like, you need to just get off of that. When in reality, they're doing great. I mean, they're not using, they're getting their lives back together. They're healthy, they're repairing relationships. There's no reason to get off of that, but people just have such a negative view of it. There's still such a stigma around it that people are just, you know, they're just still not accepting of it. And especially people that are in the recovery community themselves, like maybe people that went through a 12-step program or community, and they believe that abstinence is the only way and that has to be the end goal. And for my job, I love being able to show people that, you know, recovery is what you want it to be. It's what you want to make it to be. It's what you need it to be. Doesn't have to be linear. It doesn't have to be the exact same thing for everybody. What worked for me isn't necessarily going to work for you. And you just never know when it's going to work. I struggled for over 10 years. You know, I went to really nice 30-day inpatient programs. I went to state-run detoxes. I tried to detox on my own at home. I mean, I was on a methadone program in the past and I just wasn't ready. It just didn't work for me. I had times when I said, I'm ready. Like, this is it. You know, I was so gung-ho. I was ready. I knew I was ready. And I wasn't, you know, or I might have a year or two and then I went back. It just, you never know when it's going to work, and you don't know why necessarily. I don't know why it worked when it did for me. I'm just grateful that it did, you know? And so that's really the story that I try to tell people. Don't give up on someone because they've been to treatment 100 times or because they've relapsed for the 100th time, because you don't know, you never know. And there's no reason to give up on someone, because that's really just saying, just go die. You know, it's not going to work. What's the point? So it's really powerful to allow people to live their lives and, you know, not make them feel guilty, try to celebrate them for the small victories, and then just try to keep moving pretty much.
Thank you for sharing so openly about your experience. I think, you know, we've seen a lot of data points today, but hearing from somebody who's gone through it is a really powerful complement to that. So thank you.
You're welcome.
So we are getting close to the end. I'm not seeing any questions in the Q&A that haven't been answered yet. So if you have any final burning questions, please drop those in. My final question tonight will be, if you could wave a magic wand, what would Denver and what would Colorado look like in 10 years when it comes to decriminalizing approaches to mental health and substance use? And I did steal this question from a stakeholder meeting we had earlier. So Lisa, you are prepared, I know.
Yeah, I'll go first. I was in that meeting. Oh, it's going to be a magical world. Love, love, love. So I think there's a lot of talk about reduction of stigma. I think we need to have real conversations about that. We'll have overdose prevention centers. People will be housed and living their best lives and flourishing. We'll have decriminalization, but with decriminalization, you still have an unpredictable drug supply. So we definitely need to have regulation, a regulated drug supply. But I think, when it comes to a time where legislators are not doubling down on the worst ideas of the drug war, which are incarceration and criminalization. And unfortunately, legislators continue to try to do that in the state of Colorado. They did that in 2022 with a trash piece of legislation. They did not allow overdose prevention centers this year. So in 10 years, we will have, you know, community leaders, decision makers, and legislators that lead with a public health harm reduction lens and make sure that they follow data, evidence-based interventions, and a magical world it shall be.
There you have it. Sarah, would you like to add to that?
Yeah, if I could wave my magic wand, I have some like pretty specific asks, because sort of all of my asks come from like the vantage point of a prescriber. Like, I hold the magic pen that can prescribe the medications that can keep people alive, but I'm super limited in what I'm able to do. So, I want increased limits on buprenorphine prescribing. I want methadone out of only methadone clinics. I want methadone prescribed in primary care clinics and dispensed at pharmacies and dispensed at primary care clinics. For example, at Stout Street, we have all the infrastructure that we would need to dispense methadone. We have an amazing clinical pharmacy team. We have great prescribers. The only thing stopping us from doing that is DEA regulations and like the threat of sanctions on our license. But we know that that could be life-saving. I want more options for prescribing. I want more options for prescribing medications for opioid use disorder, like short-acting opioids for people for whom methadone and Suboxone don't work. And in some conversations that's called safe supply, and in other conversations that's called just different medications for opioid use disorder. But we have buprenorphine, we have methadone, and those are the only two things we have. They don't work for everybody. So we need expanded options of things that I can prescribe, things that actually can be dispensed and are actually available to people without making people stand in a line every single day of their lives before work. And then we need overdose prevention centers. That would be a great step as well to keeping my patients alive so that they can actually access the treatments, the expanded, hopefully, treatments that I'd be able to prescribe to them on the back end.
Thanks, Sarah. Lisa T., what would you do with your magic wand?
That our nation would have a more robust investment in helping with this epidemic. To me, I feel like they just dabble a little bit. I think there's funding out there to really, take this head on, open up more places like Fort Lyon. It doesn't have to be in a rural community, but have places for people, especially those that don't have the money to go into your Betty Fords and your Hazeltons and all that. People on the street need the help. And that's what I like about Fort Lyon is we are free to residents of Colorado. And it's needed, and we need true investment in it.
Well put. Lisa B., you can have the last word before we send it back to Alexis to close us out.
Okay, I guess I would love to see nobody dying, from drugs, especially drugs that they aren't expecting to take, like fentanyl. I had a client die a few weeks ago from, smoking methamphetamine, but he died of a fentanyl overdose. He wasn't used to that. It was literally one day before he got approved for housing the next day. And I have a 5-year-old daughter. So in 10 years, she'll be 15, which is the age that I was when I started using drugs. And I fear for her experimenting and taking even what she might think of as a prescription drug, like a Xanax or a Percocet or, something like that with fentanyl in it, because we are able to make pills and stamp them and they look just like the real thing and people have no idea. So I would just really love to see more safe supply for people that are using the drugs, that are making that choice to use those drugs, and safe use facilities, as well as just getting all of the fentanyl out of the other drugs that it's not supposed to be in, pretty much.
Well, thank you so much to our panelists. This was a really insightful and special presentation, and I hope it's changed some hearts and minds out there, and we'll continue to get this good information out to those who need to see it, especially our policymakers. So with that, I'll send it back to Alexis.
Thanks, Aubrey. And thank you again to our panelists. That was really amazing. Just want to remind everyone that next month we're going to have another session. It's going to be on older adults and homelessness. It's going to be on Thursday, August 17th. So as always, free and open to the public. We look forward to having that session. And, you know, we build sessions a few months in advance. If you ever have ideas for sessions, be sure to take the survey. We'll send an email tomorrow with all the wrap up information. So you'll get the presentation, you'll get a copy of this video. You can share it with anyone who you think needs to know this information. And you can also tell us what you think and what we can do in future sessions. So thank you all for joining. As always, we know it's a special person who chooses to come to an educational session on what are some pretty tough topics on a Thursday afternoon, evening. So thank you to our panelists, especially, and to everyone who chose to join us tonight. We appreciate it, and we'll see you next time.
Thanks for having us.
Thank you, everyone.